Hello everyone, this is my case study on chlamydia by Erin Callahan from Brandman University. Chlamydia is not only one of the most common sexually transmitted diseases in the United States, but it's also one of the most notifiable illnesses, and that is including other illnesses such as measles, tuberculosis, and other public health illnesses. Reported cases of chlamydia can be affected by several factors. Screening is one of the biggest factors. The number of infections reported could increase as more people are actually screened, even if the incidence of new cases is low. Also, over the years, more sensitive testing has come about, and expanded use of this more sensitive diagnostic test is likely increasing the number of infections that are identified and reported. Another thing is that reporting was not actually mandated in all 50 states until the year 2000. Therefore, a lot of the data before 2000 will be inconclusive. The incidence of chlamydia has been recorded as 1.7 million chlamydia cases in the United States in 2017. This equates to 528.8 cases per 100,000 population. In the year 2000 to 2011, chlamydial infections increased from 251.4 cases to 453.4 cases. That's almost double between 2000 and 2011. This was also a time, however, when they were increasing their sensitivity on the diagnostic testing, and there was a lot of advances made during that time frame to testing. Then from 2011 to 2013, the rate of cases actually decreased to 443.5 cases from 453, which is not that big of a decrease, but it was followed by an increase in the rate of reported cases over each of the next 4 years. The cost of treating sexually transmitted infections presents a huge health and economic burden to the economy. There is an indirect cost, which is loss of productivity, but this is hard to calculate because it's more focused on people not being able to go to work or not being able to do things based off of being ill from these infections. But for the purposes of this case study, we're going to focus on sequelae costs, basically complications associated with treating women for chlamydia infections. So one of the main things that women will go be treated for when they have a chlamydia infection is pelvic inflammatory disease. That would account for many visits to the emergency room and antibiotic treatment and things like that. So there is a cost associated with untreated complications, but they oftentimes combine several of the top STI, sexually transmitted infections together. It's usually chlamydia, gonorrhea, syphilis, things like that. So it's hard to find data on just one or the other. But the annual cost, per the CDC's website, the annual cost to treat curable STIs in the U.S. is $742 million. However, among these, they did say that chlamydia is the most common and most costly. Caused by the bacterium Chlamydia trachomatis. Sexually transmitted infections are spread by anal, oral, or vaginal sex with an infected individual. The infection spreads from infected individuals to their sexual partners via an unprotected vaginal, oral, or anal sexual intercourse. Symptoms are not always present. Penetrative sexual intercourse is not always necessary for the infection to be contracted. Just contact with sexual body fluids from an infected person is enough to lead to the infection. If the eyes come into contact with the infected fluids, an eye infection called trachoma may develop, which is the world's leading cause of blindness. Another method by which the infection can be transmitted is vertical transmission, and this is when a mother passes it to her baby through the vaginal canal during birth. The chlamydia bacteria invades and infects the host cells, which they depend on to provide them with nutrients for survival. If the human cells infected by the bacteria are starved of these nutrients, the bacteria die off as well. Once the chlamydia bacteria are starved of nutrients, such as vitamins or iron, they stop dividing and grow to an abnormally large size. However, these cells can remain viable and can adapt to a normal state that is ready for division again once the host cell conditions are favorable. Studies have shown that around half of infections clear within a year, while 80% disappear in 2 years and 90% within 3 years of initial infection. However, some of these infections persist and may lead to serious problems such as pelvic inflammatory disease, which is very common in women, and epididymitis in men. The bacteria can cause infertility in both men and women. In fact, chlamydia is one of the factors that I noticed in my clinical rotation that caused several women to become infertile. And later on in life, when they were trying to get pregnant, they couldn't, and came to find out that they had chlamydia when they were younger and it was never treated. And now for the case study. Tina was in the clinic for her 20-week OB checkup. She had STD testing done in her last checkup and along with some other screenings for her pregnancy. Her results for chlamydia came back positive. She was highly emotional and upset and worried about her baby's safety. She was also upset and assumed her boyfriend was cheating on her. They had been together for over 1 year and she stated she had never cheated on him. Tina also admits to never having been tested for STDs before. She notified her boyfriend, who became very angry and accused her of cheating. He came in the same day to also get tested. His test results, however, later came back negative. He then became angry again, accusing her of cheating. He threatened to leave her and the baby. The situation was very unpleasant and some education. The history and physical reveals chief complaint of STD results explanation. History of presenting illness, 27-year-old G2P1 here at 20 weeks pregnant requesting STD results. Patient is in a monogamous relationship with her boyfriend of 18 months. Patient had screening done at last checkup and is here for results. Denies any symptoms at this time. OPQRST, patient again denies symptoms at this time. Past medical history, childhood asthma, which has been resolved. Surgical history, none. Allergies, no known drug allergies. Family history, on mother's side, diabetes, hypertension. On the father's side, in her mother, diabetes and hypertension. On the father, hypertension, hyperlipidemia. Maternal grandparents, diabetes. Paternal grandfather, MI, hypertension, and cardiovascular disease. Paternal grandmother died of cancer, but patient does not know what type of cancer. Medications, prenatal vitamins, iron sulfate, folic acid. OBGYN, G2P1, AB0, 20 weeks and 2 days gestation. Last menstrual period was October 12, 2019. Fetal heart tones were recorded at 155. Fundal height was recorded at 21 centimeters. Social history, denies tobacco use, alcohol, and drugs. Review of systems was, for the most part, negative. GU was the focus today, aside from OB. She denies dysuria, denies discharge, denies vaginal bleeding or any irritation. Physical exam, height, normal, weight, 147 pounds. Again, the patient is 20 weeks pregnant. BMI 28.71. Blood pressure was 123/70. Pulse 60 beats per minute. Assessment. The primary diagnosis, ICD-10 code Z34.90, encounter for supervision of normal pregnancy, unspecified trimester. Diagnosis, differential number 2, ICD-10 code A56.8, sexually transmitted chlamydia. Clinical practice guidelines recommend diagnostic testing, which was done on her last visit, of a pelvic exam to look for external genitalia, signs of STD infections, including redness, irritation in the labia, or lesions. None of those were visible on last visit. The pelvic exam also included a swab of the cervix for GC chlamydia, which was sent off and then resulted in a positive chlamydia. Today, she will receive a prescription for azithromycin 1 gram PO times 1, and that is safe in pregnancy. She will return in 2 weeks for a recheck. Again, this patient is pregnant, so recommended treatment for uncomplicated chlamydial infection in a non-pregnant woman would be azithromycin, again, 1 gram in a single dose by mouth, or doxycycline 100 milligrams taken twice a day by mouth for 7 days. But because she's pregnant, she will receive the azithromycin 1 gram single dose by mouth. She could have also received amoxicillin 500 milligrams taken 3 times a day by mouth for 7 days. However, I feel that it is simpler to treat with one-time dose as opposed to taking a medication 3 times a day for 7 days. Normally a patient will return in 3 months for a repeat after receiving treatment for a positive chlamydia. However, this patient is pregnant and she is being seen more frequently anyways for her OB visits. So we will see her again in 2 weeks for her next OB check and to see how she's feeling after treatment. For partner testing, partners of women with confirmed or presumptive chlamydial infection should be notified in a timely manner and treated with recommended antibiotic therapy. We have requested that she call her partner and get him in here as soon as possible for testing and treatment. We've also mentioned to her safe sex practices, which include condom use, annual screening, if she's high risk, which she is in a population that is high risk, and also avoiding drugs and drinking to excess, which can lower inhibitions and lead them to making unsafe choices. We have also included handouts with patient education on chlamydia and complications of chlamydia and when to return to a provider and seek medical attention. The patient has verbalized understanding of her diagnosis and treatment going forward. I want to talk a little bit about how this case stood out in my memory for my clinical rotation, and that is because there was a lot of drama that was involved in this case. The woman, once she was informed of her positive test results, became very, very emotional and, feared the response that she would get initially from her partner, but then also was angry and just kind of assumed that her partner was unfaithful. So once the partner did come in and get tested, his test came back negative, and he immediately became angry and hostile towards the initial female patient and accused her of being unfaithful. And with both of them upset and the woman in tears, swearing up and down that she had never been with anybody since she had been with him, I went and did some research on this matter, and I did find some interesting information on the gender differences with regards to sexually transmitted infections. And I did find on the CDC page that women have some unique differences when it comes to men, and that is that the female anatomy places women at a unique risk for STD infections compared to men. So the lining of the vagina is thinner and more delicate. It's a different type of skin than what's on the male penis, so it's easier for bacteria and viruses to penetrate. So that puts her at a disadvantage. It also, the vaginal tissue is also a good environment for bacterial growth. And so in this way, many people believe, although it has been refuted in a lot of studies and articles, but a lot of people believe that it is actually easier for a female to catch or to be infected by a male than for a male to be infected by a female. So there were also some instances online that I found where a female was discovered to be positive on a pregnancy screening and her partner was later discovered to be negative. So the other thing that can contribute to those types of results is that men can be tested. In the past, they used to do cultures, urethral swabs, but they actually now do it with urine tests for men to test for chlamydia. For females, it's done by cervical swab, and the cultures were not as accurate as the PCR testing that was done. So there were sometimes false negatives. And so in this case, I tried to counsel the patient and both patients and let them know that just because they had different results didn't mean that either of them was unfaithful. It is possible to have chlamydia for months or years without symptoms. So she could have been infected from a previous relationship, or he may have very well been infected also, and the test just didn't pick it up. In conclusion, I would like to say that this clinic left an impression on me. The patients there were very wonderful and very patient and kind with me as a student, but I did notice that it was very evident the lack of awareness and education and understanding of sexually transmitted infections and how they're transmitted. This is something that I saw in this East Los Angeles clinic, and the lack of education I noticed was not just in the young population, but it was also in the older population. They were also unaware of how things were transmitted and not really understanding much of anything about sexually transmitted infections. So I did a lot of teaching within my patient visits there, but the lack of education and awareness about STIs definitely will contribute to the rate of positive tests that we saw there. I had to sit down with many patients during my clinical rotation to deliver positive test results. And in fact, a couple of them were positive HIV tests. So people just really did not grasp the severity of these results, and they really didn't understand. And in fact, I had several young girls tell me that they were on the IUD or on some type of birth control, and I had to explain to them that that does not cover sexually transmitted infections, and they just had no idea. So this is something that is near and dear to my heart. It kind of opened my eyes going to this particular clinic with high-risk population. Again, the majority of the population in this particular area is very low income, and they're 98% Hispanic with huge language barriers. Both young and older patients did not speak any English. So it will be my clinical scholarly project to introduce some implementations to create some education and some awareness and interventions to help this particular population and hopefully reduce the incidence of new infections in this small clinic and reduce the overall possibility of complications from untreated infections, but also the cost of treating infections. So that will be my project. I hope you enjoyed this presentation. Please review my references on the next 2 slides.